Hello, good afternoon. We're going to continue from where we got to the other time, and today we're looking at perioperative nursing, which includes preoperative care, intraoperative care, and postoperative care. But we'll be looking more, or we'll be talking more about the preoperative care and then the postoperative care. When we talk about the preoperative care, we are looking at the care that is given to patients before surgery or before they are taken to the OR, that's the operation room. And then the postoperative care is the care that is given to patients after surgery, so post and pre. But before we continue, we quickly summarize whatever that we did the other time. We look at surgery, we look at surgical indications, purposes of surgery, what surgical nursing was, and then we went further on to look at theater and theater settings, whatever it is in the theater, and then the theater setting, how the theater setting looks like, and then the proper attire and equipment that is needed in the theater, and the various units that are supposed to be found in the theater, as well as the theater team, their roles, their responsibility and functions. So today, at the theater, if a patient is supposed to be taken to the theater, if a patient is going for surgery, how do we prepare the patient? So patient going for surgery goes through a lot of things: psychological, physiological, socioeconomic, spiritual, and all those things. So here it is our responsibility as nurses to be able to prepare the patient well before we take the patient to the OR, that's the operation room. So first of all, we start off with what a perioperative nursing is, which embodies the preoperative, intraoperative, as I said, and then the postoperative care. So we'll be taking the preoperative and the postoperative very carefully, and we'll be looking at it from. So we're looking at perioperative nursing. So we have preoperative and postoperative care or management. This is what embodies what preoperative nursing is. But as I said briefly, we'll look at an intraoperative care. That is not too much about it. So perioperative nursing is a term used to describe the nursing care provided in the entire surgical experience of the patient. So the entire surgical experience of the patient, when the patient is going through surgery, before the patient goes through surgery, whatever entails, so far as the patient surgical condition is concerned, that is what we term as perioperative nursing. So as we said, we are describing the nursing care that we provide, the preparation that we give, whatever that we give entirely to the patient for them to experience whatever nursing care, so far as their surgical case or their surgical conditions are concerned, is what we term as perioperative nursing. So the perioperative period is divided into three phases. We have the preoperative phase, intraoperative phase, and postoperative phase, as I said earlier. With the preoperative phase, pre means before, begins. Okay, so begins with the decision to proceed with a surgical intervention is made, and ends with the transfer of the patient into the operating room. Can extend from an hour to days or even weeks. We're looking at immediately the patient accepts that they are supposed to go through a specific surgery, the decisions that they make that a surgery is supposed to be proceeded or started, and then it ends with when the patient has been moved from their lying in to the OR or ER to OR, that is the emergency room, to the operating room. In such an instances, this phase is what we term as the preoperative phase. So any preparations after that, or whatever that we do after this phase, that is what we term as the intraoperative phase. So this starts from the time the patient is received in the OR, that's the operating room, and taken out of the surgery to the post-anesthesia care unit, the PACU post-anesthesia care unit, or the recovery ward, or the ICU unit, that is the intensive care unit. So all these things, we're looking at it as intraoperative. So when the patient is received into the OR, and then when the patient is going through the surgery, the person will have to go through anesthesia and all those things before the surgery is performed. So after the surgery has been performed, before the patient is brought to the post anesthesia care unit, that's the PACU, or the recovery ward, or the intensive care unit, depending on the patient's condition at that time. Within that is what we say we have an intraoperative phase. With the postoperative phase, this phase starts from the time of admission into the PACU, that is the post-anesthesia care unit, to the follow-up evaluation. So after the patient has gone through the surgery, whatever follow-up that we are supposed to do, wound care, administration of IV fluid, medication, every care that the patient goes through after the surgery is what we term as post-operative. So we are looking at three things here: pre-operative, intraoperative, and post-operative care. But for our sake, we're going to look deeply into the pre-operative phase and then the post-operative phase. So we start with pre-operative care or the pre-operative management of patient. This period begins when the decision that surgery is to be performed. This may extend from an hour to several days, weeks, or even months. It deals with all the necessary care and preparation carried out on the client and family before the surgery. So every preparation that you are supposed to deal with before the surgery, as I said earlier on, people have not gone through certain procedures before. They have not even had surgery throughout their life. So probably if this is the first time that they are going through surgery, they are supposed to be prepared very well to relieve anxiety, stress related condition, and other things. So here we're going to take the preoperative management or care or nursing one after the other to describe it. So as we said earlier, it may extend from an hour to several days. So sometimes for you to even get people, for them to understand that they are supposed to go through surgery, it takes a longer time. Some people may be at the facility for let's say about 3-4 days and they have not even really accepted the fact that they are supposed to go through certain surgeries. So here meaning that we will be encouraging the individual to be able to understand the need for the surgery, the purpose of the surgery. We can also talk about the risk involved and how urgent the surgery also is to the individual. Maybe if it has effect on the individual's life, it has effect on the individual's appearance or outlook or whatever that it is. All these things are taken care of. So under the preoperative care, some of the care that we give or some of the preparations that we do for patients before they are taken to surgeries include psychological preparations. And this is done to just decrease the anxiety of an individual. As I said earlier, if an individual has not gone through surgery before and probably that's the first time that the person is going through surgery, a lot of things come into mind. So here psychologically the individual may not be sound, so it is our responsibility to be able to reduce anxiety on the individual, decrease the level of anxiety from the individual. So here we prepare the individual psychologically by doing the following. You have to identify the fears and concerns, pain and outcome of the surgery. So some people are just scared that just after the surgery they might not make it again. So you have to identify such fears and certain concern. Maybe they don't have money to go through such procedures. A lot of things play whereby people may be very anxious before surgery. So here you have to identify these fears and concerns to make sure that you allay these fears and anxieties to help them to be able to go through the surgery successfully. So some of the fears and concerns may be pain. The patient may be going through pain. They are thinking about the pain that they will go through after the surgery or the pain that they will go through before the surgery or the outcome of the surgery. Would the surgery be a success? Wouldn't it be a success? What are the various complications after the surgery? Patients will be thinking about all these things. So it is the responsibility of the nurses to be able to prepare these individuals psychologically. Answer questions and provide information to clients and relatives. Any question pertaining to the surgery that is going to be done on the patient, we have to really answer it and provide maximum information to the client as well as the relatives of the patient. Even though we are supposed to ensure privacy, if it deems that we are supposed to involve the patient relatives in whatever that we are doing, we have to set the record straight and make sure that we go by the hospital protocols and do as such. Visit clients on ward. We have to sometimes allow people to come and visit clients on the ward because sometimes when they see other people, it helps them to be able to allay certain fear and anxiety from these patients, and in so doing, it helps them to be able to go through a surgery successfully. Then you have to teach. You have to teach the patient deep breathing, turning, coughing, leg exercises, etc. So you have to teach these patients deep breathing exercise to calm them down, turn, coughing reflexes, leg exercises, etc. just to make sure that their nerves are a little bit calm. So these are some of the psychological preparations that we can talk about so far as preoperative care is concerned. The next preoperative care that we can also talk about is physical preparation. Before we take a patient to the OR, we are supposed to make sure that we clean the patient very well before we take the patient to the OR, because the OR area, as we learned the other time, is a sterile area which we cannot just infect the area of anything. So what happened is that you are supposed to prepare the individual physically. So this is to reduce microorganisms on the skin and prevent microbes at the site of incision, so that we don't put microorganisms in the area of incision. We don't invite microorganisms to the area of incision. Other than that, there can be other complications after the surgery. So the first thing that we look at is bathing the client before the surgery. We make sure we bath the patient, or if the patient can bath, we help the person to bath and then clean with antiseptic and shave. So if the area that is going to be involved in the incision is supposed to be shaved, it is better we help clean with antiseptic solutions and then shave them for the person. So we clean the area, we shave the area, we make sure, so we can look at trimming using powders to be able to clean the area of whatever hair that is supposed to be. Then we're looking at a physiological preparation. When we talk about the physiological preparation, we're looking at activities performed to establish a baseline data to detect abnormalities, correct imbalances, and determine the fitness of the patient for the surgery. So at some point in time, if you don't look at all these physiological preparations, patients will go through surgery and the patient will not make it. The patient didn't make it just because of the surgery, but the patient didn't make it because of inadequate physiological preparations. So there are certain activities for us to be able to know, to establish as a baseline data, for us to determine if there are any abnormalities, to correct certain imbalances. Sometimes you don't know, the patient doesn't even have fluid, the patient is dehydrated, and then you start performing the procedure. Immediately the patient starts losing fluid and blood. The patient may go into hypo or hemorrhagic shock, and then the patient may die. And then to determine the fitness, sometimes the patient has an underlying disease condition that we are supposed to make sure that the patient recovers from the condition before that surgery is done or the surgery takes place. But most of the time, if these physiological preparations are not done properly, we don't look at the underlying conditions and then we go through this surgery whilst the patient is not even fit. Then we go through the surgery and the patient loses their life. So these physiological preparations may include laboratory investigation. So we go through laboratory investigations. So one of the laboratory investigations that we can look at is urinaries. So looking at routine examination and then culture and sensitivity. So we take a urine sample, we take it to the lab, they check if there's any problem with the urine, then fine. If there's no problem, then we can continue. Blood analysis, so grouping and cross-matching and full blood count, that is white blood cell, HB, different count, and hematocrit level. We look at the hematocrit level to be able to see how adequate the individual is appreciating hemoglobin in their blood. So we look at all these counts to be able to see. Men have about 47% of hematocrit level in them. So all these things are supposed to be checked in their various percentages to be able to see if the individual is fit enough for them to be able to go through the surgery successfully. Coagulation time. The coagulation time is supposed to be calculated so that we know when blood can clot, when it cannot clot, if the individual is lacking anything that may prevent the blood from clotting. We look at all these things so that the individual may not be bleeding excessively, which the person may go into hemorrhagic shock. And finally, we have to be administering a lot of blood to the individual. Then we look at blood for sugar level, the FBS and then the RBC. We look at blood sugar level in an individual to show whether the person is diabetic or the person is not diabetic, and if the surgery is favorable for such condition and all that. We look at blood for BUE, blood for BUN, creatinine, and all these things. We look at all these things to be able to see how much urea that is existing, how much waste product that is also existing, potassium level, sodium level, phosphorus level, whether they are high or low, they are properly balanced. Then we can also take a sample of the individuals too for routine examination or for culture sensitivity. Look for specific findings in the laboratory investigation that we are having. So we take samples of an individuals to take it to the lab, look at whatever that is going on, then proper things can be done. We're looking at, after the laboratory preparations, we can further look at radiographic preparations. So if we are done with the laboratory preparations, then further investigations can also be done by imaging. So we're doing X-rays, chest X-rays, abdominal X-rays, barium mu. Barium mu is like a normal dark thing that is given through the mouth. So what happens is that it goes to color the area whereby there's a deformity, there's a problem. So if it colors the area, and after you have taken an imaging, you'll be able to see the abnormality at that site, which is going to be colored very well by the barium meal or enema. We can also do cholecystography. Then we can do IVU and IVP. We find meanings for IVU, IVP. ECG, etc. So we do ECG, we look for rehydration. By rehydrating the individual, IV fluids are given to correct electrolytes imbalance, and then dehydration are corrected. And where patient is on diet, quality and quantity of diet is increased. So we're looking at the quality of the diet that we are giving the individual and the quantity of it. If you are supposed to give less or you are supposed to give more, you are supposed to prepare the patient properly for. So sometimes a patient may be going through surgery. They may see that the patient lack a specific nutrient. So sometimes what it is done is that we have to put the individual on diet for some time. So after the person stays on diet for some time, meaning that the person will be able to meet the requirements so far as the surgery is concerned. And then finally, we can look at transfusion and correction of anemia. We transfuse with blood. So blood transfusion will correct the anemia. That is the loss of blood in any other form. So obesity and weight control. So obese people are guided to cut down weight by reducing caloric intake and, if possible, engage in tolerable exercises to cut down fat. So they are cutting down weight, they are reducing their weight, they are cutting down fat so that they can be able to have access to a proper structured surgery. Then supervise to perform bathing and coughing exercises. As we said, deep breathing exercises, reflexes exercises, leg exercises, and all those things. All these things are supposed to be supervised. Insert tubes as may be required. Rouse tube, urethral catheter, flatus tube, that is NG tube, or the Rouse tube, another. So we can look at all these things to be able to see if there is a need because the patient is going for surgeries. The next preparation that we can also look at is spiritual preparation. Ask if patient wishes to see a pastor, a chaplain, an imam, or perform special ritual prior to their surgery, especially with the JWs. Some of them don't take blood, or let's say the JWs as we know them, they don't take blood religiously. So such people are supposed to be asked, in case there's a major surgery in which they are going to lose a lot of blood, what would they do? So spiritually, whatever that they believe, because you are supposed to put whatever that each and every person believe into consideration. So if they want to see a pastor, if they want to see the chaplain of the facility, an imam, or maybe perform a spiritual something just to be able to protect them, whatever that it is due. So far as the facilities protocols are concerned, we are supposed to observe all those things. We are not supposed to deprive any patient of spiritual preparations because psychologically it may have effect on them, and then patients may even lose their life throughout processes of surgery. The next one is legal preparations. There's legalities in nursing and almost every part of every institution. So here, to be free from certain legal issues, it is the responsibility of surgeons to make sure that patients consent to the surgery. They don't just stand up and just do any surgery for anybody. You don't know what may happen. So they have to just first consent. So it is the responsibility of the surgeon to explain the procedure to the patient to make sure that whatever possible complication that may arise during the processes of the surgery are spelled out to the patient so that at the end of the day, the surgeon, the nurses, or the whole theater team is not sued for something that was expected. So every complication, so far as the surgery is done, must be spelled out to the patient so that the patient may consent to it, so that it takes certain headaches from the healthcare providers. So this should be repeated by the nurse after the surgeon has explained. You read the consent form to the client and let client read and understand before signing, or the witness also signing it on behalf of the client if the client, let's say, is unconscious or is a child, a minor. Pre-operative care, so no sedative should be administered to client before signing consent form, because some of them can tell you, I was not even myself when I was signing the consent form, so I didn't really know what I was signing because I couldn't see properly. So no sedative should be administered to clients before they sign a consent form. They are supposed to be of sound mind before they they sign a consent form. So guardians sign for minors and unconscious clients. This is witnessed by the nurse. So after the guardian, a relative of an unconscious patient has signed the consent form, it is supposed to be witnessed by a nurse, so that the nurse will countersign with whatever the relative also signed. We have to know that signing consent form has legal implications. Therefore, whoever signs the form is fully responsible. If it is the client, then such an individual must be 18 years and above in Ghana, or by the age legally defined for a minor in a particular country. So every country has got certain ages that are defined by minors. So in addition, the person must be fully conscious with sound mind. In case of any of the above problems, the consent form is signed on behalf of the patient by a relative. And if the relatives are not available, the doctor takes responsibility. So let's say that in an accident scene, patients have been brought to the facility, patient is unconscious, can't even wake patient up, we don't know anything about the patient. Then it is the responsibility of the doctor to do the surgery on behalf, because meaning that the individual is a property of the state. So according to property, according to protocols, it is the responsibility. If the individual, there are no relatives can be found, the individual is unconscious and the patient is dying. In certain critical situations like that, it is the responsibility of the doctor to be able to go ahead with the surgery regardless, because it is the doctor's oath to be able to save life. So emancipated minors, these are persons below 18 years of the legally defined age of a minor who are permitted to sign the consent form. The acquisition of this seal is defined by social status of being socioeconomically independent, fending for themselves, married, etc. So if the person is not at the legal age of 18, but the person is fending for him or herself, the person is married, or whatever the case may be, these group of people are termed as emancipated minors, meaning that they can sign the consent form by themselves. But apart from these indications, meaning that if an individual is minor below the ages of 18 years in Ghana, it is the responsibility of the relative to be able to sign consent form on behalf of them. Apart from that, above 18 years, or let's say 18 years and above, it is the responsibility of the client to be able to go ahead and sign these consent forms. Socioeconomic reparations. Whenever we're going through surgery, then a lot of things come into play, especially if it has to do with money. So the socioeconomic problems that arise are discussed with the patient family in order to find solutions. So some of these problems are role performance concern. The caregiver inquires about patient's social role and responsibility, address concern regarding the effect of the illness on him and others. Some of these role concerns are breadwinning, governance, for example, assemblyman, an MP, etc. So sometimes we have to define the role performance of the individual in the society. So who is the person? What does he do? What does she do? We have to look at all these things, especially if the person is a breadwinner in a family, if the person is holding a specific status in the society, such as an MP or an assemblyman. How is the surgery going to have effect on such positions? So we have to also look at all these things before the surgery commences. Hospital bills. The nurse establishes patient's ability to pay for cost of care, and if he or she cannot afford to pay, then the social welfare department is notified. So sometimes some patients are brought to the facility for where we know nothing about them, and they need urgent surgeries, emergency surgeries. So when such emergency surgeries are needed by such patients, then the social welfare is notified. And some people are indigent, they are extremely poor, for which they cannot afford any health care. So in such situations, the social welfare is notified that such people need this. So whatever the social welfare people will come out with, then the facility takes it up from there. Job. Assessing the impact of the operation on the patient job and offer solutions where necessary. So what job is the person into, and what would they be doing after the surgery? So is the surgery going to impact on their job? Are they going to be jobless? Are they not going to be able to replicate the same strength and effort or put into their job the same way as they used to be? All these things are supposed to be discussed. Family support. The patient's family members are educated and consented to organize the impact of their support on the well-being of the patient. Sometimes patients may go through certain procedure, and after that they are dejected by their family members, so they need the support of their family to be able to rise up and come back to their normal frame of life and just work. Perception of the patient on illness and its cause must be addressed. For instance, some patients attribute the cause of illness to spiritual entities such as witchcraft, ancestral spirits, gods, juju, and etc. So the perceptions of certain patients are supposed to also be cleared before surgeries are done. People have epilepsy, for which they attribute it to spirituality. People have fibroid, for which they attribute it to spirituality, and a whole lot of things. So in such situations, if certain people like patients who have fibroid and they are supposed to come and they are going to churches, they are praying for the fibroid to melt and all those things. In certain situations, we are supposed to look at the conception that these people have so far as the illness or the condition is concerned and clear those conceptions from their mind and tell them that it can be medically resolved for them, so that they don't concentrate on only spiritual aspects, even though the spiritual aspect is also needed for their day and day survival. So gastrointestinal preparations. So stomach and bowel. The rationale behind the gastrointestinal preparation is that it's done to reduce intestinal bacteria and risk of injury to the colon. So we are reducing the risk of injury to the intestines, and then any form of injury, perforation or whatever. So it is the responsibility of the surgical team to be able to prepare the individual bowel so that they are not going to have any problem so far as bacteria and colon injury are concerned. So the stomach, the jejunum, the duodenum, and the proximal jejunum we want to talk about. Diet and laxative drugs are used most often, and about 72 hours to the surgery, light diet such as agidi soup, rice porridge is given, followed by fluid diet such as light soup, porridge or tea with milk, mashed agidi or kenke the next day. So these are light and easily digestible foods that will allow the patient to be able to digest it early so that surgery can proceed. 24 hours to surgery, about 200 to 300 ml of clear fluid diet such as tea, orange juice, soft drinks are given at 2 to 4 hourly intervals. The patient takes nothing by mouth, that is nil per us, after midnight until the time of the surgery. So if the surgery is delayed, IV fluid may be set up. For any indication that may allow the surgery to delay, there's a possibility that we give IV fluid in replacement of any fluid loss. If laxatives are to be used, they are usually beginning about 48 to 72 hours. Prior surgery and stop about 24 hours to surgery. Some laxatives used are like castor oil preparations or tab ducolas. In place of this, 2 large glasses, that is 250 ml 2 times, or 5% mannitol taken orally every 1 to 2 hours from midday till evening is also what's recommended. So these are some of the things that we can do. So if you are going to use laxative, this is the processes to which you are supposed to go through in administration of the laxative. So from the 48 to 72 hours of the surgery, prior to the surgery, we stop it within the last 24 hours before the surgery is commenced. So a bowel preparation depends on facility policy and the surgeon's discretion. Some health authorities advocate enema, while others do not, but prefer the use of laxatives alone. So some also believe in the use of diet alone or diet and enema, or the combination of both laxative and enema. For many reasons, enema is no longer emphasized. For many reasons for which you are supposed to tell me, I am sure. So some people may decide to use enema, laxatives, diet alone, enema alone, laxatives alone. So it depends on the facility's policy or the discretion of the surgeon who is performing the procedure and how they really want the patient to go through the surgery properly. Pre-operative, evening before the surgery, client should bath or shower and shampoo her hair to remove excess body dirt and oil from their body. Remove all nail polish and makeup. Jewelry and other valuables should be removed. Make sure all other laboratory investigations are done. Teach patients the fasting guidelines, what they are supposed to eat, what they are not supposed to eat, and at what pace does things that they have eaten that digest. Make sure drugs, fluids, and other relevant items are ready and prepared for the procedure. Preparation on the day of the surgery. Client should have another bath and shower using an antiseptic soap to prevent the multiplication of microorganisms and invasion of microorganisms. A complete mouth care is vital to provide comfort for the client to prevent aspiration of small food particles in case they are already inserted. Catheter is supposed to be passed. Vital signs are checked and recorded. You recheck the surgical list to see if that is the right patient, age, sex, right condition. You check every particular to see that everything is properly available. Laboratory investigations have been fully carried out. And finally, consent form is signed. If ordered, administer preoperative treatment. Example, midazolam. So you give preoperative treatment like midazolam. You have to tell me what midazolam is and then what it does to the individual. Report unexpected findings or any deviations from normal. Emergency pre-op. If it has to do with emergency cases and urgent surgery, we have to do it because the patient's life is at risk. So we check the hemoglobin level and blood group compatibility to be able to see if you are supposed to give blood, then we give. Start with normal saline, plasma expander, example, hemocell. So you start with plasma expander, hemocell, so that you can get enough blood. Empty the stomach if it is full, and then general anesthesia is to be administered. You pass a Foley catheter and you test the urine. You sign the consent form, remove dentures and jewelry if there are any, have clients if there is shave clients if there is any, or when it is necessary. Suction airway if excess secretion are found in the airway, so you have to make sure airway is patent, the person is breathing, and you just have to check for circulation. Then administer oxygen if it is necessary throughout the surgery. If vomiting occurs, the head should be kept lower so that the individual doesn't aspirate the vomiters. Maintenance of adequate circulation. Hemorrhage. You have to make sure that blood is flowing to the various parts of the body so that especially the heart, meaning that the heart is pumping, the heart is working, blood is moving out to the various parts of the body so that there is not going to be any form of necrosis at any part of the body. Prevent by observing for bleeding at incision site. So whenever there is a bleeding at the incision site, it is suction to make sure that the field is very clear for whatever that is supposed to be done at the area or the part of the body whereby the surgery is taking place is done. You check vitals to detect shock and hypotension. So always all the time when an individual is going through surgery, there are monitors that are attached to the patient, so they'll be monitoring the vital signs to be able to see any fluctuations or any discrepancy that is found within the vital signs. They are reported so that whatever is supposed to be done throughout the surgery is done. Safety. Intra-outral phase, as we talk about. Safety. Ensure you have a controlled environment. Effectively manage human resources, equipment, and supplies for individualized patient care. So every patient that you are dealing with and the amount of people and supplies that is needed for that specific surgery is supposed to be available. So safety, you don't have to get a lot of people in there. You don't have to, as we talked about the other time, in the theater team, we see the surgeon assistants, anesthetists or anesthesiologists. You see some students, and so just few people are what is needed at the OR. We don't need a lot of people just to minimize safety. And then transfer patients to operating room or bed table. So from there, we move the patient to the operating room or the surgery. Then position the patient, functional alignment, exposure for surgical site. So you position the patient at the right area whereby the surgery is going to take place. You put the patient in a proper position. You apply grounding device to the patient. You have to make sure that whatever that is needed for the patient's care before the patients go through the surgery, everything is made readily available. Ensure that the sponge, needle, and instruments counts are correct. So here, whatever instrument that you are going to use, needles, sponge, cotton, everything that you'll be using throughout the surgery, make sure that you count them correctly and then it is written there. So after the surgery, we recount them just to make sure that we have not left anything within the patient. Complete intraoperative documentation. So whatever went through, so far as the surgery was concerned, it has to be written down. Physiologic monitoring. Calculate effect on patient of excessive fluid loss or gain. So throughout the procedure, whatever fluid that the patient is losing, whatever fluid that the patient is gaining, all those things are supposed to be calculated. so that we can get a proper balances. Distinguishes normal from abnormal cardiopulmonary data. So that's why the monitor is always available to be able to look at the heart sound whenever there's any form of deviation, and then it is noticed. Report changes in patient vital signs. So during the processes of surgery, whenever there is a change in the vital signs, whether it is elevated or whether it is depreciated, whatever that happens throughout the vital signs of the patient, it is recorded and reported so that an intervention can be done before the patient dies. Institute measures to promote normothermia. So here we are supposed to make sure that there's a normal temperature. So any measure that will give us a normal temperature throughout the procedure, we are supposed to institute it. Psychological support before induction. Provides emotional support to patient, stands near or touches the patient during procedure and induction, continues to assess patient emotional status. Some of them throughout the procedure, they might not be very stable. Okay, so perform the rest of your function as either a scrub nurse or a circulating nurse, which we talked about the difference between a scrub nurse and a circulating nurse. So this is the end of perioperative nursing. That is the introduction of the perioperative nursing. And then the post-operative phase. So we look out for the post-operative phase. In the post-operative phase, we're looking at after the patient has been brought back from the theater, the various things that we're supposed to look out for after the patient has been brought back from the theater. So meaning that surgery was a success, we are supposed to move the patient from the OR to the recovery ward to a PACU or to an ICU. So with all these things, the first thing that we're looking at is post-anesthesia care unit. So here, after anesthesia, post-anesthesia, after the administration of anesthesia, earlier on we said that before patients go through surgery, we give them anesthesia. Something that will block or to numb pains and prevent them from feeling whatever that is going on. Sometimes we give a general anesthesia or regional anesthesia. Sometimes we also give a local anesthesia at the site to which the surgery is going to be performed. So here, so that the patient doesn't feel pain or whatsoever that it is. And then we have types of anesthesia that could be given to patients. We won't go through that. So to ensure continuity of care from the intraoperative phase to the immediate postoperative phase, a circulating nurse anesthesiologist or a nurse anesthetist will give a thorough report on the PACU to the PACU nurse. So here what happened is that we give throughout the procedure whatever went on. Was the anesthesia enough? Was it calculated well? The amount, was it okay? All these things are calculated before. So when they get to the PACU nurse, then they just give every report to the PACU nurse. So this should include the following: the type of surgery performed and any intraoperative complication. So during the procedure, any complication that arises during the procedure, it has to be reported. The type of anesthesia, general, local, or sedation. So sometimes you're supposed to sedate the individual for the person to sleep so that they don't look at whatever that is going on. Or they are giving general anesthesia or local anesthesia. Any of that form is understandable. Drains and type of dressing. So the type of dressing that was used to reinforce so that the individual may not be bleeding. That draining tubes, catheter, we're looking at Foley catheters or whatever, NG tubes, whatever that was inserted here has to be noted. Presence of ET tube and or any type of oxygen delivery device, let's say nasal cannula, a T-pipe, a nasal mask, whatever that type of it has to be noted. Types of lines and location. Example, peripheral IV, central line, arterial line, whatever type of IV that was used or whatever type of lines and its location are supposed to be stipulated. Then we're looking at catheter or tubes such as a Foley catheter or T-tube. Any of them are supposed to be recorded with a type. Administration of blood, colloids, and fluid and electrolyte balance. So sometimes a blood is administered to an individual. Sometimes colloids are also administered to an individual. Colloids are administered to an individual. Sometimes we give fluid to also make sure that we have electrolyte balances and all that. When we talk about somebody who asks about colloids, we're looking at colloid as a homogeneous and non-crystalline substance consisting of large molecules and ultra microscopic particles of one substance dispersed through a second substance. So sometimes we don't actually give blood. Sometimes we are just supposed to give other molecules either than blood, okay, or either suspensions either than blood that are referred. So meaning that a specific imbalances is supposed to be corrected somewhere instead of a whole blood being transfused to an individual. So we're looking at drug allergies. Whatever the person is allergic to has to be noted in the post anesthesia care. Pre-existing medical condition, any conditions that was there before the procedure was done is supposed to also be noted so that we don't give any medication that is contraindicated. Nursing assessment. So before receiving the patient, note a proper function of monitoring and suction devices, oxygen therapy equipment, and all other equipment. So the following initial assessment is made by the nurse in the PACU. So verify the patient's identity, the operative procedure, and the surgeon who performed the procedure so that in case of any emergency, you can still call the surgeon for that. Evaluate the following signs and verify their level of stability with the anesthesiologist: respiratory status, circulatory status, temperature, and oxygen saturation. So you are supposed to look at the SpO2 of the individual to see if the individual has a higher. So if you go to certain facilities, an SpO2 of about 80 meaning you are supposed to give oxygen. So meaning higher, 100%, then meaning the individual sustains. Respiratory status, if the individual has established a proper respiratory status, the person is breathing well. Circulatory impairment or status, we're looking at temperature, and that's why we said nomothermia. So nomothermia meaning that you want to establish a normal temperature of an individual. So when all these things are fluctuating, meaning that it's supposed to be reported. So that is what the nurses are supposed to do an assessment on. Determining swallowing, gag reflexes, and patient's response to stimuli. When the patient is pinch, the patient is supposed to swallow, the patient is supposed to do that. All these things the patient are responding. That is after the procedure. Evaluate lines, tubes, or drains. Estimate blood loss, condition of the wound, open, closed, or packed. Medication used, infusion and including transfusions and outfits. So you have to make sure that you are evaluating the lines, the tube, the IV tubes that was used. Make sure you know the condition of the wound. If the wound is still open, if it is closed, if it was closed, what was it closed with? Or if it was packed, what was packed in there? Evaluate the patient level of comfort and safety by indicators such as pain and protective reflexes. So you have to let them show you how they're experiencing pain and other reflexes. Perform safety checks to verify the side rails are in place and restraint are properly applied as needed. So the side rails of the bed are lifted just to make sure that the patient is restrained and then prevented from also injuring themselves by falling. So evaluate activity status, movement of extremities, review the healthcare providers' orders. Standard of care guidelines. So after every procedure or after every surgery, these are the standard of care guidelines that most of the time it is established before every patient. So you check vital signs, administer oxygen if it is necessary, you check temperature, which is adequately part of the vital signs, change the patient's position and observe progress of activity, ambulating watch for dizziness or nausea. So you have to check the vital signs almost every 15 minutes if it is stable for the next hour. You check for 30 minutes if it is stable for the next hour. Then you do hourly. If it is stable, then you go on to our normal 4-hour check-in. And then you have to check the SpO2 if there's any form of fluctuation, and if there's a need for administration of oxygen, those things are done. And you have to make sure that the patient has a normal range of temperature so that the patient doesn't spike any. Whenever there's a spike of temperatures, meaning that there's a possibility that an infection somewhere has set in, so it has to be cross-checked to prevent sepsis. Standard of care guidelines. So we look at checking vital signs. At least one are the patient stands without dizziness and any form of nauseous, begins to walk by themselves, comfortable, and then free of excessive pain or bleeding. The patient is able to drink fluid and void, urinate, orientated as to time, place, and person. They know where they are, they know the people that are close to them, they know what time is it. No evidence of respiratory depression, that's 2 hours after intubation. Has the services of responsible adults who can escort the patient home and remain with the patient, and then understand post-operative instruction and take an instruction sheet home. If the patient has a proper education, you have to give them patient education guideline for them to be able to look at that. So most patients experience some discomfort post-operatively. These are usually related to general anesthesia, a surgical procedure. But the most common ones that we can talk about is pain, nausea and vomiting, restlessness, sleeplessness, airway obstruction, constipation, cough, and flatulence. So these are some of the basic things patients will be feeling so discomforted about after surgery as a result of either the general anesthesia or the procedure that they went through first. So nursing standard of procedure. So what is the patient's problem, the actual and potential nursing diagnosis, nursing orders, expected outcome, intervention, and evaluation. So we're looking at the patient problem. What is the patient problem? Patient problem, probably the patient has pain. What would be your nursing diagnosis? What's brought about the pain? Nursing orders. So what would you do? An expected outcome. After what you have done, what are you expecting? And then what will you do about it? An intervention. And after that, is your goal met, partially met, or not met at all? After whatever that you have done for the patient, you have to make sure that you do a nursing diagnosing to be able to see whatever that is going on. So this is the end of our post-operative phase as well. So we have dealt with um, pre-operative and post-operative phase, and briefly we talked about the intraoperative phase. So what we did today is we looked at a perioperative nursing, introduction to perioperative nursing, and in the introduction of perioperative nursing, we said that the entire care that is given to patients so far as the surgical procedures are concerned with what we term as perioperative nursing. So in such an instance, we are looking at the pre-operative preparations, intraoperative preparations, and post-operative preparation. So we have looked at the pre-operative preparations are the preparations that is given to patients prior to surgery or before to surgery. Intraoperative preparations are the preparations that is done during the surgery, and then the post-operative preparations are the preparations that is done after the surgery. So we would break from here. If there's any other examples, any other comments, any other questions, we'll take it in the group and then we'll move on from there. Tomorrow we would start with cell injury. We were supposed to do or look at inflammation, but on much ado, we start with cell injury. Before we understand the concept of inflammation properly, we have to look at cell injury and cellular adaptations, and from there we can look at inflammation. So without much ado, we will end the class here. If there's any other question, you can post it in the group and then we can sort ourselves out of the group. Thank you very much for listening. You are warmly welcome.